Welcome to the Physician Associate Podcast.
Hello and welcome to this episode of the Physician Associate Podcast. My name is James. Today I'm delighted to be joined by Dr. Liz O'Riordan for the podcast, a very special episode. And Liz, thank you so much for coming on the Physician Associate Podcast today.
You're welcome. I can't wait to chat.
I was wondering how best to introduce you, and I think you sort of summed it up well yourself, saying you are a breast surgeon who has had breast cancer.
That's right. How ironic can you get?
And I thought it would be really useful for physician associates, for other clinicians, just to hear a bit about your story and to touch on subjects about how, as clinicians, we can look after ourselves and our colleagues, and how we can have meaningful conversations for patients with terminal diagnoses and those kind of things. So do you want to start by sort of introducing yourself and explaining your story?
Yeah. So I've spent most of my life training to be a surgeon. I was the most boring person you could imagine because all I did was eat, sleep, work, repeat. And I was a consultant surgeon at Ipswich Hospital when in 2015, at the age of 40, I was diagnosed with stage 3 breast cancer. I just thought it was a cyst. I had no family history. I was a triathlete. I had no real risk factors. And suddenly I was facing chemotherapy 2 weeks later. And I thought I knew everything there was to know about breast cancer. It was my job. And I realized I knew nothing. I had no idea what it was actually like for patients to go through the treatments I prescribed, to consent for surgery, to come out the other side. It was really, really hard. And I went back to work for about a year, which I struggled with because I wanted to give patients a hug and say, yes, this is terrible and I can help you through. But I couldn't because I still have to be the bad guy. And then I got a local recurrence on my chest wall in 2018. And the side effects of that treatment meant my left arm didn't move properly. And I had to retire as a surgeon. So the illness I spent my life training to treat robbed me of my career. And I've had to learn how to help people in other ways, but also how to become a more balanced person.
Thank you for your honesty and for explaining all of that. It must have been quite a shock when it first sunk in. Were you diagnosed by a colleague? Were you in the
Yes.
breast clinic that you worked as a patient?
So I wasn't treated in my own hospital. Although I had a cyst, I just didn't want my own team talking about me. So I went down the road to West Suffolk, where my husband's a surgeon, and I saw the woman who trained me. She was a mentor and a friend. And again, we just thought it was a cyst. My mammogram was normal, and then I had an ultrasound scan of the lump. And I looked at the screen and I knew it was cancer. And because it was big and I was young, I knew I'd need chemotherapy, a mastectomy. I had a good idea what my 10-year survival was because it's my job. So whereas most patients are drip-fed information, and you'll know this, they have a test, they have a symptom, they have a biopsy, they get a result, they have a surgery, they get the result. I knew everything, the good, the bad, and the ugly. And it was my job to decide how much of that to tell my husband and my parents. And I've looked after women who died of metastatic breast cancer, and it was so hard not to see myself in their place. And I've almost went into denial. It's not happening. It can't be happening. It's happening to someone else. And I almost became a patient so I could dissociate that.
We use sometimes the term an expert patient in clinical practice, and we talk about patients who know so much about their own condition, but you can't get much more expert than a consultant in their own field with the disease.
No.
Do you think that was a blessing? Was that a curse? Was that also very difficult for your colleagues and your mentors to...
I think it was a curse. I think doctors generally make terrible patients. We think we know what we're going through, but we haven't because we've never been there before. And I made so many mistakes. I knew chemo would make me ill, but I didn't realize how ill. So I wouldn't ask for help because I thought I should be able to cope because I'm a doctor. It's also incredibly hard for colleagues because they either assume you know what's happening, so they don't give you the normal spiel, the normal consent. They miss bits out. Or they're too scared to come and talk to you. Or they can't cope, or they're nosy, they want to find out what's wrong. It's really, really hard. I had incredible care, but I'm sure it was different care to what a normal patient would have. And God, you see the look in their eyes when they know what you've got. Everyone was crying when I was told I had cancer. It's like, this is really, really strange. But it's very hard for I was in with, I had an infection during chemo, and it was incredibly hard for the junior doctors looking after me. How would you feel as, your first day as a physician's associate, going to see a consultant's wife who's a consultant surgeon who's in hospital, terrified of taking blood? It's really, really hard.
Yeah, it's something that must be very difficult to imagine what that feels like without having gone through that experience.
Yeah. And I think, because I would often treat nurses as a consultant and other doctors, and I say, I am going to assume you know nothing, so I tell you everything I have to, and then we can go into a more complex discussion. But I will assume that because you're a patient. And I would tell doctors seeing me, like the anaesthetist, assume I know nothing, because otherwise you'll forget something important, or you won't tell me what I need to know. And actually, I've not had an operation before. And I think that can really help just set the scene.
Did you find that people treated you differently because of your position as a consultant, for better or for worse, do you think?
It's hard to know, because this is the only time in my life I've really been ill. I don't think I got extra special treatment. I think I had the same standard of care that everyone had, but I think the way they reacted to me, there was a lot of sympathy and knowing looks, because we all knew what was going on. And going into theatre, being operated on by the team of people I'd worked with, that was really, really emotional for all of us. I think it was just as hard for them to work with my operation as it was for me as a patient to go through it. When I did go into hospital with an infection during chemo, it was a bank holiday Friday, it was payday, it was 10 o'clock at night, and A&E is the last place you want to go. And I could have said, I'm a consultant surgeon and my husband's the medical director and I want to be seen now, but I didn't. I wanted to see what it was like for my patients. And it was amazing care, but it's just that I didn't want to abuse who I was, but I'm sure it was a very different experience to other people.
Initially, you were able to return to work, weren't you, and continue practicing as a consultant. Did you find that you could cope with having to deliver diagnoses and news to your patients? Could you put a professional hat on, or was it different having been through it yourself?
Firstly, it was hard going back to work, because I was given a 1 month return to full-time work. And I didn't realize after cancer, you're legally disabled. And your employer has to make reasonable adjustments to allow you to return to work. Having been off for a year with chemo, with my own illness, there was no way. And I physically couldn't cope with working full-time. So I shadowed Adam Brooks for 6 months, just because as a consultant, you're not appraised anymore. As you're going through training, you have certain criteria you have to meet to say, yes, you can do your job, tick. Yes, you can break bad news, tick. As a consultant, it's assumed you can do it. And no one knew how to assess whether I, as a consultant, could do my job. So I went to Adam Brooks, where I didn't work with them, so they wouldn't be biased. They could be honest and say, Liz, you're not up for it. And the first time I saw a consultant break bad news to a woman, and she was younger than me, she broke down in tears, and I struggled to hold it together. And all I could see was, God, that's how my husband and I looked when we found out. And you see the stiff upper lip and the wobble and the looking at the floor and the squeezing their hands. And it was just that flashback. God, I can never, ever do this again. And when I had to do it myself, I want to say, yes, this is swear word. You're going to think this is the worst thing in the world. And I get that, but we're going to help. And I was told, you can't tell them it's bad. It's just a little cancer. It's fine. We've got to be positive. Like, no, you don't get it. No matter how small it is, it's still cancer. And when you hear those words, it is the end of the world. And you have to allow patients time to absorb that. And I think one of the problems, we all have training in breaking bad news, and we all have certain phrases that we use. I used to say a biopsy is like getting a core of an apple, and I can tell you it's an apple, but not whether it's a golden delicious or a Bramley. And I assumed patients understand that. I've heard of a colleague who would tell people that it was like a terrorist invading a hotel. Now, I don't know how I would react if I heard that, but to him, that made sense. But we know what we're going to say going into that room. We've been in an MDT meeting. We've discussed the cases. We know what they've got. We've been able to say in private, that's not good. And then we go in and say, right, it's cancer. But to that patient, it's coming out of the blue. Even if they're expecting it, it's still a shock. And what we should do is then stop and count to 10 in our heads and sit on our hands and let that news sink in. And listen to the first question that patient asks, which can dramatically change what you do. Often it's, will my hair fall out? But it could be, who's going to look after my disabled father? Or what about the horses? Or can I return to work? And they're allowed to get that initial, oh my goodness, question out. Whereas if we say, which is what I used to do, okay, it's cancer, and can I examine you? And you need a mastectomy. And you go through your spiel, you're not giving them time to assimilate. And often it's just as they're leaving the door, but they don't want to bother you. So they never get to tell you what's really on their mind. And then it's just battered away and can come up later. And I knew what I was being told. I knew the consent. I knew everything my consultant was telling me because she trained me. But I was still going, swear word, it's cancer. All I want to do is run out of this room and swear and shout and cry and why me? And it's not on. But I have to pretend to listen to all this stuff. And then what patients have to do is to go back, especially during COVID where they've been alone, is to then be a doctor to their family. What did the doctor say? They said this, but you can't remember what you said. It's not accurate. And it's just, you've got no idea the aftermath of breaking bad news. And it could be as simple as, I'm sorry, your scan's been cancelled. Your operation's been delayed. I'm really sorry. The aftermath, when you leave, you have no idea until you've actually been on the other side.
Absolutely. It's something that we're all taught as at PA school, breaking bad news, and we're assessed on it in OSCE stations. But I think perhaps until you've been in the shoes yourself, it really doesn't hit home the way it should. And
I think so. I used to tell patients, don't Google, because I will give you the pile of leaflets you will never read to take home with you. Because Google's a scary place. Bollocks. It's the first thing I did. And I'm a consultant breast surgeon. And I bought 10 books written by patients to find out what it would be like to be a patient. And I'm a consultant breast surgeon. What we should be telling patients is, firstly, after breaking bad news, you always have a plan. If you are told to tell someone their operation's cancelled, you need to know, when is it going to be rearranged? Who do they call? You have to give them a plan so they know what's going to happen. And you signpost them online. I had never looked at a breast cancer website or forum. I had no idea the kinds of questions patients were asking. But if you can say, okay, these are safe places. This is a safe place to get more information and remember what I've said. That would dramatically improve the quality of patient care overnight. Because it's the first thing you would do, James, if your mum or your dad or you were suddenly ill. You go on Google. You don't go to the NHS website. You don't go to 111. You don't go to the NICE guidelines. It's Google, it's blogs, it's the internet. And if we can direct people to safe resources that they can read in their own time and revisit, it would be huge. And the easiest way to do that is to ask patients with the disease in follow-up clinics, what websites, apps, forums, books helped you? Can you give me a list so I can pass on to every other patient? Because we, as patients, have done the hard work.
Do you mind talking about chemotherapy and what that situation was like and what you learnt going through that process?
I used to give chemotherapy if there was a 5% benefit, it would work, which means it doesn't work in 95% of women, but we have to put everyone through it. And I wouldn't see patients during chemo. Often it was done after surgery. Sometimes I'd see them if they had it up front to try and shrink the tumour. And I'd see these women who are a shell of their former selves. But I didn't really know what it was like. I used to say, yes, you'll lose your hair and you might not work. And it was a weird, sick sense of excitement to see what it would be like. I know it makes no sense at all, but that loss of control, going into the chemo suite on the first day with my port and the look of sorrow because I was the youngest one in there by a good 20 or 30 years. And they hook you up to these drugs and they give you a load of tablets to take. And then you're sent home with a huge party bag of tablets for all the side effects. And you go home thinking, when will it start? And I was fine for the first 12 hours. My nose started to twitch and I lost my sense of taste. And then it gets worse. And it was 4 or 5 days of the worst: cold, hangover, flu of your life, sickness, bone pain, constipation. God, I hadn't gone for 10 days, crying on the toilet, naked with bleeding piles and a fissure. I felt like an old lady taking laxatives. I couldn't think. Chemo causes permanent brain damage. It biologically ages you by 10 years. I still get words confused. I'll call a pencil an elephant. I don't. It was hard. It was so hard to lose all. I didn't realize you lost your pubic hair. All the hair on your body goes. Who knew? I didn't know that. The headaches, everything. It was horrible. But you don't want to tell people it's horrible because they go through it. And people a lot older than me have to go through chemo. And I lost the sense of feeling in my fingertips, peripheral neuropathy, and that could be permanent. But God, I may never operate again. I couldn't open a button. I couldn't hold a cup of tea because I couldn't feel it. There was so much I didn't know. Doctors told me what would happen, but it was other patients who told me how to cope, to use a baby toothbrush and biotin toothpaste that wouldn't affect, and the bleeding gums, and what to eat when everything tastes horrible. It affects every single part of your life. But now I can't remember it. It's almost like my mind has blocked it out. But every time I get hungover or a bad cold, I'm right back there again. It's not Smarties, and I don't know whether I would want to go through it again.
I don't know if this is a fair question to ask, and feel free not to if you don't want to. With your husband also being a consultant surgeon, the impact of your treatment and your illness and the chemo that you went through must have had such an impact on your friends and your family as well. Was that something that you were prepared for? Is that something you've learned from how those closest to you were affected?
I wasn't prepared for it. And my parents had moved, I'm based in Suffolk. My parents had moved to Scotland a couple of months before I was diagnosed. My brother lived in Switzerland. So my immediate family were hundreds of miles away. It was just me and my husband. And thank God I had treatment. I'm so lucky to be treated in the hospital where he worked, because it meant his colleagues would cover for him. He could come to all my appointments with me. And by coming out and telling Twitter I had breast cancer the day after, I didn't want people gossiping about me behind my back. They'd recognize me with no hair. It meant that my husband's colleagues knew. And if he was having a wobble, they could comfort him. I found it very hard to show him and my parents how I was feeling. And I would sit on the floor and cry in the shower when he'd gone to work, because I didn't want to burden him with that. He said he felt impotent going to work, leaving me recovering from chemo on the sofa looking like death warmed up, because there was nothing he could do to help. And I think it's almost harder for him, because I was surrounded by flowers and cards and presents and how's Liz and how's Liz, but very few people ask, how's the husband, how's the wife, how are the kids, because they have to go through it as well. And I think one of the hard parts of breast cancer especially is I felt I was no longer a woman. I'd lost my hormones. I had no sex drive. I'd lost my hair. I'd lost my breast. And I've met many women who felt the same as me. They wanted their husbands to divorce them and go and find a woman with 2 breasts and a libido, because he didn't sign up for this. You know, after a couple of years of marriage, that guilt that you feel, you say sickness and health, but when sickness happens, that guilt, it drives a lot of couples apart. And I am so lucky to have had him by my side as my rock, but it's tough. You realize what love really is and what it really means to care and to look after somebody.
One of the questions I was thinking about asking you was around identity and how that changed how you saw yourself, and perhaps how other people see you as well. Being a doctor and then not being a surgeon and not being able to operate any longer, it must have pulled the rug out from underneath you. Completely.
And I think before I was diagnosed, my identity was a surgeon. I'm a surgeon, I'm a PhD, this is what I do. You know, it's all I talk about because it's all my life, because I have a boring life, I don't do anything outside of it. I'm a surgeon. And then I became a breast cancer patient. And it's all anybody talked to me about, breast cancer. I thought, God, I'm Liz. I'm Liz. Please talk to me about something other than cancer. This is boring. But everyone wants to know because they didn't know anyone else who'd been through it. So they're curious. And then I went back to work, and that was quite hard. But when it came back and I had to stop, I felt I had completely lost my identity, not just as a surgeon, but as a woman. Who am I? I don't have ovaries. I don't have a breast. I lost my hair. I've lost my job. I've lost my source of income. I want to help people, but I can't do that anymore. And then realizing that I had no life outside of surgery because I'd lost all the hobbies and everything I used to do. And that was the depression that comes from a cancer diagnosis and the impact. I'd also lost my ability to be a mum. Chemo made me infertile. And I became a step granny. But I can't make clothes for my own kids. And it is different. And it took time. And I think social media saved me. The support I had from other patients and doctors on Twitter saved my life. And I could talk to people who've got it. And I now use that. I write and I do videos to help explain, to help people. And I get that sense of, you want validation. You want to help people, but you want them to say thank you. And that, for me, that's that way of helping people and giving back. And I think I help far more people now doing what I do than I ever did as a breast surgeon. But it's weird because I just still see me sat here in my dog walking clothes in the middle of Suffolk. I don't really see the impact I have on the outside world. And I get people come up to me at airports. Oh my goodness, Liz, I'm in. Can I have a selfie? Me? Really? I don't see that impact because I live in such a, it's like a weird kind of crazy double life. But I am happier and more fulfilled, and my life is much more balanced than I ever thought it would be. And I've worked hard to see the positives. And yes, I still worry every day, is this the day it comes back? But I don't dwell on that anymore. I think it comes back to doctors looking after themselves. We don't look after ourselves. We go the extra mile. I used to live off cereal and bagels. I didn't have time to cook. You don't sleep. The house is a mess. We don't see friends. Could you do this shift? Especially in the last couple of years, my physical self-care. I didn't exercise regularly. I joined a gym and never went. Mental health care. Yes, I have all the signs of depression, anxiety, and stress, but that's normal because I'm a doctor. And it's only when the rug is pulled out under your feet, either through illness or someone else is being ill, you think, actually, am I actually healthy? And how can I say no to something at work because it's not good for my physical or mental health? And it often takes a crisis. So I had severe depression twice as a consultant, and I carried on working until it was almost too dangerous for me to work. But you can't say no. You have to go in because who's going to see the patient? And you feel guilty that you're ill because you're letting your patients down and your colleagues down. And it's trying to remind anyone listening that you are human and you will get ill, and it is okay to take that time off and to say, no, I cannot do that because I will get ill. And if you can't handle that, then I don't want to work, or I have to work for you anymore. But do you know what I mean?
Absolutely. Yeah. I was going to ask, one of the things you mentioned earlier was you were doing triathlons and were quite fit. Have you been able to recover some fitness after your illness and after your treatment? Has that been helpful?
I'm glad you asked that. It's one of my pet passions. When I was a cycling widow. And I only started cycling because Dermot got a bike, and then suddenly I was riding with him. But I got bored. I wanted something for me. And I ran the marathon very badly when I was 30, and I used to swim. So I started doing triathlons. I'd done my first one 6 months before I was diagnosed, and I'd been cycling in the mountains in Italy. It was a really important part of my life. Plus, I like the bling. You get a medal even if you're last. I have a huge collection of shiny medals. I want more. I am that shallow. When I was diagnosed, no one told me to exercise. It wasn't mentioned. I was almost told not to. But I found women on Twitter who had metastatic cancer, who were still kayaking and rowing and weightlifting. I thought, right, I'm going to carry on. I won't tell my doctors because they'll tell me not to, but I know what my body can handle. So I went to the gym in my chemo good weeks and did body weight lifting. And I started doing park runs, and I would cycle to chemo. I did a sprint triathlon in a pool halfway through chemo. And I had to promise to be sensible, but I was really, really slow. That sense of achievement. And we now know that exercise, if you get on a bike 2 weeks before your surgery, it can improve your outcome, reduce the complications, reduce the length of stay. If you exercise during chemo, it will halve the side effects. It will improve the fatigue, improve the mental health. If you exercise when treatment is finished, it can halve the risk of recurrence of some cancers. It should be the first treatment doctors tell you to do, or a contract. I'm going to spend hundreds of thousands of pounds giving you all this treatment. you need to exercise to double the impact of that treatment. I've had to learn that I'm slower and I'm not as fast and I'm not as fit, and stop comparing my post-cancer times to my pre-cancer times. But I weight train, I cycle, I run. It gives me control. And I'm just Liz when I'm out there, whether it's walking the dogs or riding a bike. And it's now a huge part of my life, which is crazy because I avoided sport at school. I didn't do it. I couldn't hit or throw or catch a ball to save my life. But it's something that every healthcare professional should be talking to every patient about.
Is there some advice or some lessons you've learned on how we can check in on each other as healthcare professionals for our own mental health, physical health as well? But were there things that you remember people asking you that were helpful, or really wish you hadn't asked me that and phrased it that kind of way?
I think it's really hard with colleagues because you're friendly with them at work, but are they your friends? And only one of my colleagues at work stayed in touch with me. The rest didn't. And I got really upset about that at first. But then I thought, I didn't talk to them normally outside of work. And life moves on. And sometimes if people know you have an illness, they back away. And I had friends I've lost touch with, but people who I was at school with when I was 7, who are now really close. And illness affects people differently. They're either too scared to think of what you're happening, or they just can't deal with it. So it's being aware that your friends aren't always who you think you are. But with their colleagues at work, it can be really hard to check in because do you want to pop a bubble? They're just holding it together. And if you pop that bubble, you're the one to help pick up the pieces. And there's also, a friend had this. One of her colleagues, she was a radiologist, and she'd had cancer and she'd come back and she couldn't cope with reviewing scans of patients who'd cancer. And it came to the point that they couldn't talk about it in an MDT, influencing the work of everyone else who's ill. And I didn't see that. But now I realize, me being back at work, did that mean people were treading on eggshells? So I think for people who have an illness, it's worth working out what you want people to know and what you want them to talk about. And maybe getting your line manager to send a round robin to say they're coming back. They don't want to talk about why they've been off. Don't ask them. Just carry on like normal, whatever it is that you want. But I think if you're part of a team of people, you do need to be able to check in. And I started called it a cuddle club. It's crazy. Instead of the timeout, I'm in clinics and I break people. You've got a cancer. It's come back. Cry, 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 cry. And I was always the last person to finish that clinic. And there's no one to debrief with. And I have to go home on a Friday and suddenly turn into Liz, the wife and friend. But then I said, right, can we all just hang on and can we just talk about what we've seen in the clinic and who made you laugh and who made you cry? And that little debrief was a way of everyone just offloading a little bit of emotion and sharing it. So we went home a little bit lighter. And I think doing that at the end of every half day, at the end of every clinic, ward round, how are you? Are you okay? Just keeping it really light. But I think that knowing that you're there for someone and that they can share the good and the bad is okay. I think it's also really important that you all know where to go for help in your hospital, whether that is occupational health or they have confidential lines. And you could say, are you all right? You might not want to talk to me, but did you know you can go here for help? And remembering, it's the old cliche that a difficult colleague is a colleague in difficulty, but a lot of us act out because there's shit going on. And we're not just a stroppy cow, but actually we're concerned that our husband might have cancer. And it's just having that, if someone's acting out, are you all right? I might be the person you want to talk to, but you could go here. It's knowing how they can pick up the pieces if you do say something. But I think for me, one of the things I started doing, I hate having to do something every day. You hear about gratitude diaries or journals, or you write in 3 good things that happened every day. And sometimes it could be really blooming hard to do that. But I invented a thing called a jar of joy, because my chemo hadn't worked and my lymph nodes were positive. And I just thought, what's the end? What's the point? This is the end of the world. I'm going to mope for the rest of my days. I thought, no, I can't do that. I've got an old glass jar and I've got a load of Post-it notes. And every time something good happens, I put it in the jar. And it could be finding a fiver down the back of a sofa, or the birds singing, or not having to go round and round and round for a car parking space. You just, oh, there's one and I can zoom in and this is perfect. And I'm not late for work anymore. It's not every day. And just seeing that build up makes me smile. and I'll read a few out, and actually having one in a ward or in the mess or in your office, and you get people to anonymously just put in good things that happened. And it's a really nice way of reminding you that even when people are dying and in their last hours, you can still hold their hand and give them a smile. You can bring someone comfort. And I think that's a really nice thing to think about for you, for family, for work, just as a way of checking in.
I love that idea. Yeah. Just remembering some of the happier times when you need them.
Yeah, but you must find it really hard when people check in with you. It may be the wrong time, or you bat them off, or you don't know what to say, because we are not trained. We're not psychologists. We've all got our own stuff going on. It's really, really hard. But I just think knowing where the support services are and where you can say, look, I'm just a bit worried about you. If you want to chat to me, I'm here. But just putting it there. Maybe. I don't know.
You mentioned around death and people in their final hours and what you can do to help. And I know it's something you've transitioned into, isn't it? Is being a consultant and learning from death and how to die well. Do you think it's something that we, as a profession, clinical profession, do we get it right? Do we do well with death?
So I've spent the last couple of years reviewing the notes of everyone. A lot of people have died at the hospital, and there's a lot of good, but there's a lot of bad. And it's often the little things. And I'm not talking about cases where we've got it wrong, got the wrong diagnosis. I think it comes down to doctors and nurses are uncomfortable talking about death and telling patients they are dying. And all too often, we don't tell them they are dying. We may tell the family they're dying, but we use words like they're seriously ill, they're really grave, they might not make it. And then we do one more test or one more referral because we are trained to save people. And the families get that there's hope because you're doing one more test. Or they might not make it, but they might. They don't understand. And there's a brilliant book by Catherine Mannix called With the End in Mind. She's a palliative care consultant. And I tell all the junior doctors this. 4 words: sick enough to die. If you say those words to the patient and their family, they will understand that death might be a result of this illness, and it sinks in. We used to say, never say the word cancer. It's neoplasm or malignancy. You have to say the word cancer. And when someone isn't told that they're dying, they don't have a chance to get their affairs in order, to do a will, to tell Auntie Joan that they really hate them, whatever it is, whatever they want to do. And we're almost depriving them of their last 5 senses. So someone on death row gets to choose their last meal. But if you don't tell someone they're dying whilst they are awake and have capacity, their last meal may be an Ensure drink that's warm, that's come out of a fridge that's been sitting there. I might want a glass of gin and tonic and a piece of cold chocolate whilst I can still taste and swallow. I want to hear birds. I want some fresh air. These are my last. I want to smell this. I want to hug that person. If we don't tell them, and we don't because we're scared and they don't need to know because I'll just go into a coma, I think we're doing them a disservice. And I also think we're very bad at recognising people are dying. And the Royal College of Physicians have got a great booklet about saying what the signs are. People who haven't got out of bed or they've been in for a while, and actually saying 1 in 2 of us are going to die in hospital. And I asked a group of East of England matrons where they wanted to die, and none of them said a hospital. And that tells you something. Hospices have a few number of beds. There might not be one available. A lot of us are going to die in hospital. And it's accepting that patients may die naturally, and that's okay. And what can we do to make that better for them? To tell their family to bring in duvets and photograph frames. And almost, I'd love it to be, if someone is on end-of-life care, they are in their last days or weeks of life, then they're not in a hospital. They're not at home or in a hospice. They are being cared for, and get palliative care in early. So many people think palliative care is for the last hours of life, but those doctors and nurses are amazing. They are for symptom control, and they will do the holistic, the spiritual discussions. They'll talk to the family. They'll make sure everyone knows what's going on. They are your friends. And all too often I saw written in the notes, low threshold for calling palliative care. How much lower does it need to be? How much more suffering does this patient need to have? And often it's a junior doctor in the middle of the night who is making the referral because they don't know what to do. It should be seen as a positive thing. The best that might happen is they get better. They leave hospital with fabulous supportive care. And I think it's realizing people die. And a lot of people in hospital die, and that's not your fault. And you can't save everybody, and give them that chance to say, what would you like? Do you want more treatment? For me, it's that honest, open communication and accepting it's not a failure. Does that make sense?
Yeah, absolutely. Some of the phrases you used as examples of what not to say, I have thought about, I probably used in conversations this week with families, and it's so important to be frank about what's going on.
We do it based on what we've heard our colleagues say. And all too often it's the euphemisms, because I don't want to be that blunt, and then what will happen? But actually, sick enough to die means they might not die, but it means that death is on the table and everyone has heard that word. And it may mean the family can think, right, okay, what do we need to do just in case? Because we get what might happen.
For physician associates as well, it's important to know how to handle those conversations correctly, because we don't rotate like the doctors do. We often are in service in post for several years. In oncology services, in any specialty really, you'll get to see the same patients coming back and meet their families, and you can be that person who is a point of continuity and be the one to have these difficult conversations.
And it's okay to show emotion. If you know someone and they've come back in with progression or a recurrence, it's all right for you to get upset and to show that emotion. Say, oh, this is shit, I'm really sorry. Because you are a person, and it is okay to show your emotion and provide comfort if you have a relationship with that patient, and give them that space to talk to you, because you're almost the continuity. But then you have to know who to offload that emotion onto.
Yeah.
And that's where you have to be able to debrief with one of the doctors on the team or one of the nurses to say, oh my goodness, this is really hard. I'm struggling. There are patients you'll see that you just can't cope, and you need to make sure you have a way of offloading that or dealing with that, so you don't go home and just bottle it all up, because it's really hard when you're dealing, especially with cancer patients.
Having been so honest and open to tell your story, it's led, I suppose, your career into another part for you, isn't it? And you're now sort of a speaker and an author and a presenter, and you've been on the BBC and you've been in all the newspapers and written books. And how's that process been, being able to share what's happened to you in these ways?
I started writing a blog. My husband told me to, because he was a tech geek at the time. And it was a way of making it real, because I was still in denial. And from that blog, I got messages, comments from medical students, doctors, patients saying, thank you for explaining this. And I realized I had a gift for writing in a way that people could understand. And then I got asked to do a TED Talk by a pediatric surgeon I knew on Twitter. And that was terrifying, standing up on that stage. But I learned how to talk properly. And the purpose of a talk is to help the audience, not to tell them what you want to tell them, which is what most conferences are. I'm going to tell you my slides and they're all really busy and you can't read them and I'm wonderful. It's like, why does the audience give a toss that you're there? How can you help them? And I learned how to talk. And the first time it was really emotional. I was crying on the stage. But then when you see a room full of people crying, it's a bit like a drug. And it's a bit like the acting in theatre or in hospital, the grand round and the theatre. And I realised I quite like making grown men cry, telling them my story and making them think. And if I can make just one person in that room change how they treat patients, then I've done my job. And it's a new way of helping. And it's not just about cancer care. It's about resilience and looking after yourself and how to cope when things go wrong. And it is much more enjoyable because I do it every day, whereas I had one operating list a week. And it's just, I never thought this would happen, that I would have a new career like this where I can help people all over the world. And I love it. But the hard part for me is I get 30 or 40 or 50 messages a day from people all over the world, often asking for advice or sharing their stories. And it's hard to remember to prioritize me. And I need to learn to say no again and realize that my job for me at the moment is writing or helping my life, not the 40,000 followers who want me to ask them a question. And that's hard when you put yourself out there to realize that time balance, and you don't owe them anything. They're almost lucky to get what you give them, but then you want to carry on helping. And it's hard to find that balance again, but I love it.
Bless you. Thank you. Liz, thank you so much for giving up your time to share your story and to be so frank and so honest about what you've learned through this experience that you've gone through. It's such a unique perspective, and I think will really help a lot of clinicians and a lot of physician associates who listen to this and just take pause for thought and consider the importance of self-care and the words they use with patients.
It's such an important message.
If it's sparked questions, causes for concern, worries, or people want to find out more about you and your story and need support, where would you flag people to go to find out a bit more?
So to find out a bit more about me, you can go to my website, which is liz.o'riordan.co.uk. If you've got any questions about breast cancer, I wrote the book, The Complete Guide to Breast Cancer, which just takes you from beginning to end. You can find me on social media, Twitter and Instagram, just search for Liz O'Riordan. And I just say, be kind to yourself. Medicine is a hard job, and you need to remember that you are a patient as well.
Perfect. Thank you. I'll leave links to your website and your fantastic book in the show notes of this episode, so people can find them there. And if people are interested in finding out more about physician associates in breast surgery itself, I've done another episode with a fantastic PA who works in breast surgery and her consultant. So you can look for that back on the feed for the show as well. Thanks for listening. I hope you found that a really useful chat. If you've got any ideas for future episodes of the Physician Associate Podcast, please get in touch. I'm on social media at PA Podcast UK, and I hope you'll join me again for the next episode.
Thanks for listening to the Physician Associate Podcast.